You have to mention. And you must say the detailed history of the appendicular mass being treated. Are you able to take any history regarding the appendicular mass?
Yes.
How
How
it
was it
started?
diagnosed? How was that appendicular mass diagnosed the first time?
Previously,
The patient had a fever or pain.
Yes, ma'am. Previously, the patient came with
history. Okay.
Previously, the patient came with a lump and pain in the right iliac fossa, for which he only underwent ultrasonography, and it was diagnosed to be an appendicular lump in the ultrasound, for which he was treated conservatively. After that, his pain got subsided, the mass was decreased, for which he was discharged. This was the history in the month of May.
Advised for interval appendicectomy. Did you take that history?
Excuse me, ma'am. I didn't get you, ma'am.
No, the patient was advised for an interval appendicectomy. Did you take that history or been advised for an appendicectomy?
The patient was advised for interval appendicectomy, but due to the ongoing corona pandemic, he could not revisit the hospital, ma'am.
Okay.
Richard.
Yes, sir.
In retrospect, do you think in a 62-year-old male with a lump in right iliac fossa, just an ultrasound would is sufficient in retrospect now?
No, sir.
So what would you have done then?
I would have gone for a CCT of the whole abdomen.
Okay. Anything else? Anything more specific?
No, sir is asking whether you have been investigated the patient for in view of malignancy. Just you have treated the patient for appendicular mass. Did you evaluate the patient for an malignancy? Sir is asking that. I hope, sir. Isn't it, sir?
Yes. I think a colonoscopy would have been. Do you think decrease in size? Decrease in size. If it is a malignant, will it decrease in size?
No, sir.
So that I mean, okay. You've taken a detailed history about sleep. Why do you take a history of sleep? His sleep pattern is okay, normal. Anything important about that?
Well, just for the general well-being of the patient, sir. If the patient has a decreased sleep, or a decreased sleep.
In a case of malignancy, what is the importance of sleep? Can there be changes in sleep pattern if there is a secondaries in the brain, or if there's liver secondaries in the liver? Well, there can be. Also, you've taken a very detailed history about social history. What is the importance of social history in this patient? You've taken his middle class, Pakka house, tap water, LPG, sanitary latrine. Importance of all this. Why did you take it? There is importance. I'm not, but there must be a reason why you asked.
History of gastroenteritis. He may present with mesenteric lymphadenitis, sir.
I mean, cooking on LPG will not cause, or cooking on stove will not cause gastroenteritis.
No, sir. Just for lower socioeconomic status, sir.
Right. In cases of malignancy, social support is very important. If he's living in a proper house, there can be social support, because malignancies will have prolonged treatment. It will be a drain on his finances. So that's why you've got to take.
Sir, Rajiv sir, it also helps in Government of India, sir. No.
Right, it does. Sir. And immunization history is not important in a 62-year-old male. Please, I mean, 62-year-old male with immunization history. I don't know what I think it's just not done, right?
Okay, sir.
Right. So, what do you think in your history? What you're dealing with?
Richard, did you?
Yes, sir.
In your history, you have used 3 words.
Yes, sir.
No radiation of the pain, no shifting of the pain, no referral pain.
Yes, sir.
These 3 words you have specifically used. What do they mean? There is no radiation, shifting, or referral of the pain.
A radiation of a pain can be a pain which is in the site of the pathology, and also presenting in a same dermatome, sir. A shifting of pain can be.
Now, give an example in that area, which you can say that probably that is a radiation of the pain?
Sir,
Give some
suppose a
example
patient,
of that.
sir,
Yeah.
a patient presents with an peptic ulcer with the pain in the epigastric region. He may complain of radiation of the pain to the back, sir.
No, I am asking about the right iliac fossa. Your main presentation is the right iliac fossa, isn't it?
Yes, sir.
So give some example in the right area,
Yes,
right
sir.
lumbar region, right iliac fossa region of
So
the radiation of the pain.
a patient with a right uretary colic may present with a radiation of pain to the groin or the groin region, sir,
Even it
or
can
inner
go to the
thigh.
testes, no?
Testes
Can
as
go
well,
to the
sir. Yes, sir.
testes, right.
Yes, sir.
Okay, tell about the shifting pain.
Shifting pain in case of a right iliac fossa, sir. Initially, the pain will be, for example, in case of acute appendicitis, initially the pain will be in the umbilical area, sir, and then slowly it will shift to, sir, right iliac fossa, sir.
Okay.
In umbilical, in the McBurney's point, sir.
Right. Now tell about the referral pain.
Referral pain, sir. The site of pathology and the complaint of pain are totally different, sir. Sir, like, sir, in the diaphragm, sir, irritation of the diaphragm the patient will complain of pain in the shoulder, sir.
Okay.
Yes, sir.
Now, another thing which you use is about the bowel habits. Now tell what is the difference between a altered bowel habits and the alternating bowel habits.
Sir, altered bowel habits is in like the regular bowel habits which he has been having, that has changed. Suppose a person has been having a morning and evening passage evacuation of bowel. Now it has changed to maybe 2 or 3 days after a period of 2 or 3 days or something like that, sir.
And what
And
is alternating bowel habit?
alternating bowel habit has been, sir, like there is alternating between constipation and diarrhea, sir.
Right. Give a classical example of the alternating bowel habit in the surgical patient.
Sir, left colonic growth, sir.
Right. So why does there is an alternating bowel habit in the left colonic growth?
Sir,
what are the reasons for that?
Sir, left colonic growth usually present with intestinal obstruction, sir. So the fecal matters get impacted. The impacted fecal matters will cause irritation to the walls of the cecum, causing
Other word you tell about what is the difference between a left colonic malignancy and the right colonic malignancy in terms of history only?
Sir,
what are the reasons for the difference here?
Left colonic malignancy will usually present with features of obstruction, sir. Whereas
that's what I am asking. Why there is alternating bowel habit on the left side? Give the reasons for that. What are the causes or the etiology for the alternating bowel habit on the left side? Okay, there are three reasons. There are three reasons for that.
Yes, sir.
One is, what is the lumen between the right and the left side? What is the difference?
The right side, the lumen, sir, is bigger than the left side of the lumen, sir. The cecum
right
is,
side is bigger than the left.
Right side around the cecum is 5 to 7.5 centimeters, sir. Right. And in the left side, sir, rectosigmoid is around 2.3 to 2.5 centimeters, sir.
Okay, so one is the lumen.
Yes,
second
sir.
Is the
content of the stool, sir.
Content of the stool which is there.
Right side.
And third is the type of the malignancy which is there. What is the difference in the type of the malignancy?
In the right side, sir, we usually find, sir, ulcerative or cauliflower type of growth, sir.
Right.
And in the left side, sir, we get tubular or annular type of growth, sir.
Right. So because of these three reasons, you know what is a stercoral ulcer?
Yes, sir. The impacted stool in the left side, they cause irritation to the bowel wall and then cause, sir, irritation, and that leads to, sir, ulcerations.
Yeah, so there is a lot of the mucus formation is there because of these stercoral ulcer. Yes, so that is why you get the alternating bowel habit on the left side, because the patient passes the mucus, which is a pseudo type of diarrhea, and he thinks he's relieved of the constipation. Then he start taking the laxatives, and again he becomes constipated. So that is why there is a constipation alternating with the pseudo type of the diarrhea. So that is a typical the alternating bowel habit.
Yes.
Right. Okay.
Richard,
Yes, sir.
Richard, you said this patient might have had appendicitis. Based on what grounds you said 6 months back he might have had appendicitis?
Sir,
Forget about the ultrasound. Now tell me,
yes,
what
sir.
was the clinical grounds? Why did
Yes,
you
sir.
tell he might have had appendicitis?
Patient presented with the typical features of sir pain in the right iliac fossa, and it was that the tenderness was present in the McBurney's point, sir.
That
And
is
there was a
not,
lump. There was a lump, so we it was thought
that
to be
is
an
not,
appendicular.
that is not typical of appendicitis, right? Iliac fossa pain. What is typical of appendicitis? Initial pain.
Initial pain will be in the umbilical region,
So
sir.
what is that
And
called
then it
as?
will
What is that called as? What is this?
migration of pain, sir.
Okay, all right. Let us say a patient might not have told you. All right. Did she ever have fever?
In the
Did the patient has fever that time? No, I just want to ask him to know idea where. No, my question
actually, what happened? This patient came 6 months back. That time we didn't see. It was treated by another group of surgeons.
Sir,
so this time we had histories and other things, papers, but not detailed.
Sir, I'm just trying to ask him some little questions, sir. That's all.
Yeah, go ahead. But we didn't examine the patient 6 months back.
I just want to ask. That's all right, Richard. I just want to ask you, in the absence of the fever and vomiting, let us say, not questioning that.
Yes, sir.
My question to you is, can anything else can present as a mass there?
Yes, sir.
What?
That will come in differential diagnosis, I think.
No. What is the classical presentation of
sir, there will be, sir, there will be migration of pain. There will be fever.
No, forget
nausea,
about migration of the pain.
Fever,
I will
nausea,
give an example. Can carcinoma of the cecum can present as intersusception? I will ask you one question.
Yes, sir.
Yes.
So when the examiner wants to ask you in a different way, so some of the things you should know. Carcinoma cecum is notoriously can present as a mass, which you may think as appendicular mass. It may be an intersusception. Carcinoma of the cecum can present as severe anemia. Anemia, not necessarily due to the bleeding. Okay, it can have a bone marrow depression. And elderly people, it is not uncommon to get appendicitis when it blocks the lumen. So radiation reflecting pain. Also ask about backache. Backache means psoas spasm. You understand? Psoas spasm. Yes. Don't say psoas abscess. Say
psoas spasm.
Infiltrating the posterior
infiltration to the psoas muscles.
These are the few things you should know. So when they ask you, examiner ask you, you should be ready with that. So in the absence of bleeding per rectum and all that thing, what can you think of anything else in the right iliac fossa? The patient does not have bleeding at all, no mucus also.
No, sir.
So can anything be compressing on the cecum? I just want to know from you. That's all. Hello.
Yes, sir. Sir, hypertrophy.
Yes.
Yes, sir.
When a patient does not have bleeding per rectum, I agree it is some kind of stools have become semi-solid. Yes, otherwise, there is not much of support for you to say the GI because you are not yet examined the patient. So you also should keep it in mind, something which may be extraluminal. Is it clear?
Yes, sir.
Something. I'm not telling to support my diagnosis or something, but also you should remember in the absence of the bleeding. All right. Yes, that's all from my side.
Please go ahead, Richard.
Yes,
Shantani ma'am, please.
Can go ahead with the general examination, Richard.
Yes, sir. Yes, ma'am.
Okay.
General examination. The patient is alert, conscious, cooperative, well oriented to time, place, and person. Weight is 49 kilograms. Height 164 centimeter. BMI of 18.2. ECOG performance status of 1. Decubitus is of choice. Build is average. Nutrition adequate. Patient looks ill. The condition of the hair and skin is normal. The tongue and oral cavity normal. Pallor is present. Icterus absent. Cyanosis absent. Dehydration absent. Clubbing absent. Edema absent. JVP not raised. Neck veins not engorged. Neck glands not palpable. Temperature is normal. Respiration 16 beats per minute. Regular in rhythm. And abdominothoracic type. Blood pressure is 110 by 70 millimeters of mercury, measured in the right upper arm in a supine position. Pulse is 70 beats per minute, regular in rhythm, normal in volume and character, with normal arterial wall condition, no radioradial delay or radiofemoral delay. Peripheral pulse are bilaterally and symmetrically palpable. The abdominal examination, it was done in a supine position after taking consent and explaining the procedure to the patient and ensuring proper privacy. We started our examination. Exposures from the nipple to the mid thigh. On inspection, the shape of the abdomen, it was flat with fullness in the right lower abdomen. The position of the umbilicus is in the midline and inverted. Movement of the abdomen. All the regions move equally with respiration. There is no visible peristalsis. The description of the visible swelling. The visible swelling is present. And the site and the extent is from the right iliac fossa till the right lumbar region. Size is 5 centimeter to into 5 centimeter approximately. Shape is globular. Condition of the skin over the swelling is normal. No movement with respiration. No engorged veins or visible peristalsis. Hernial sites intact. Scrotum normal with bilateral testis present. Supraclavicular lymph nodes, no swelling seen. Palpation, the superficial palpation. Temperature, no local rise of temperature. Tenderness present over the swelling. The feel of the abdomen is soft. On deep palpation, the position of the lump. The lump extends from the right iliac fossa. In the right iliac fossa, the size is 4 centimeter in vertical dimension and 7 centimeter in horizontal dimension. The shape is globular. The surface is irregular. Margins irregular, well defined. Getting all around the swelling was possible. Consistency hard. No movement with respiration. The lump is fixed. It is an intra-abdominal swelling confirmed by lab rising test. No pulsations present, and it was not palatable bimanually. Upon percussion, there was dull knot over the lump, shifting dullness and fluid thrill absent. Liver dullness was present in the fifth intercostal space, and the liver span is 12 centimeter in the mid-clavicular line. Auscultation. Bowel sounds heard, no bruit heard over the lump. Examination of the back and spine. No spinal deformity. Renal angles not full. Renal angle and spine not tender. Loin percussion resonant. Digital rectal examination. No skin tag, fissure, fistula, external hemorrhoids noted. Anal tone normal. Mucosa normal. No palpable mass or signs of pelvic deposition. Proctoscopy, normal anal mucosa, no visible lump. The case summary. My patient is a 62-year-old male, Mason, hailing from Patiagaon, Jorhat, was admitted to Jorhat Medical College and Hospital on 23rd of October with the complaints of lump in the right lower abdomen for 6 months and pain in the right lower abdomen for 1 month. He also has loss of appetite, weight loss, and change in the consistency of the stool. There is fullness in the right iliac fossa. Lump is solitary, globular, intra-abdominal and tender, hard in consistency, with irregular and ill-defined margins and irregular surface. of size 4 centimeter in vertical direction and 5 centimeter in horizontal direction, involving the right iliac fossa, and is fixed. From the history given and examination findings, the patient is provisionally diagnosed to be a case of carcinoma cecum. And the differential diagnosis: ileocecal tuberculosis, Crohn's disease, Schwartz cold abscess, and the lymph nodes.
Okay,
Okay.
Richard.
Richard,
Yes, ma'am.
Richard,
Yes,
in your general examination, you've written as edema absent. What's that edema? Where it is edema? Is it a generalized edema or a pedal? You
pedal
have to
edema.
mention that. You should not write just like that, edema absent. Okay, then go
Yes,
back
ma'am.
to your inspectory finding. Just, okay. Just tell your inspectory finding again.
The shape of the abdomen, it was
No,
flat
with the picture, I could
fullness.
see only the fullness. I'm not able to
Fullness
see
in
whether
the
it is
right.
5 cross 5 centimeter globular, like swelling in the abdomen. It is in the inspectory finding. You are able to see 5 cross 5 centimeter. I could see only
It
the
was
fullness.
approximately. I just
No, there is a fullness
on
in
inspection.
that too compared to the left iliac fossa. There is a fullness in the right iliac
Fullness.
fossa.
Yes, ma'am.
Okay.
Yes, ma'am.
No, I can tell you, ma'am. This swelling is visible. If you see
Okay,
tangentially or sideways, visible swelling. We can see the swelling.
Okay, sir. Okay, sir. Then, did you mention anything in the ascitic fluid or something? Fluid
Yes,
in the
ma'am.
abdomen?
Yes, ma'am.
What test you have done for that?
Ma'am, we checked for fluid thrill and shifting dullness, and both were negative. We came to a conclusion there is
Fluid
no
thrill and shifting. So, we need to
shifting
do the
dullness.
shifting dullness.
Richard, complete your statement. Shifting dullness.
For shifting dullness and all, how much of fluid you need, Richard?
Around 500 ml, ma'am. 50 ml.
No, 50 ml is, you can diagnose only by ultrasound, 50 ml.
You said that this lump is not bimanually ballotable. What does that mean? What is the meaning of that?
Upon taking the lump between the two hands in the with the
No. Is the bimanual palpation and the ballotment are the same things or different?
Ballotment is, sir, if the patient if the lump is mobile when pushed from the down, and then if it is felt on the upper hand, sir, when pushed from the lower hand.
So tell me how you do a bimanual palpation and how you do a ballotment.
Bimanual palpation, we push the lump to above, and with the examining hand we will feel the lump. But in the bimanually ballotable, we'll just give a jerk, so that we'll push the lump above, sir. So whether it's felt on the examining finger.
No, in both cases you are going to use your both hands.
Both hands, yes, sir.
One will be in the anterior side and another will be in the posterior side.
Posterior side, sir.
Right, usually in the renal area.
Yes, sir.
So when you're doing the bimanual palpation, then your both hands move. Anterior as well as the posterior hand both will move.
Yes.
But in a case of ballotment, you will push from one side and you will feel on the other side, either anteriorly or posteriorly.
Yes,
because which are the lumps which are ballotable and which are the lumps which are bimanual palpation? Give an example of a ballotable lump and give the example of bimanual palpation lump.
Any lump arising from the kidney is bimanually ballotable, sir.
Don't confuse. Bimanually ballotable is nothing. What's your written? Either a lump is bimanually palpable or it is a ballotable. Both are the different things.
Yes.
Okay.
Yes, sir.
So ballotable lump is like a lump which is from the kidney, but it is a smaller lump.
Yes, sir.
Okay. But there
Yes.
can be a big lump from the kidney, like a hydronephrosis is there, big hydronephrosis. Then
Yes,
it will
sir.
be bimanual palpable lump.
Palpable. Yes, sir.
Right. Yeah. Okay, now tell, how did you measure the lever span?
Sir, liver span we measured in the mid-clavicular line by percussing from above, second intercostal space. We are percussing downwards in the
How do you know
mid-clavicular
where
line.
is the second intercostal space?
The second intercostal space corresponds with the, sir, it corresponds with the sternal angle, sir.
No, it doesn't correspond to the sternal angle.
One intercostal space below the sternal angle, sir.
No. Sternal angle is in the midline. So first you will feel for the sternal angle. How will you feel for the sternal angle? That where is the sternal angle?
Sir, from the sternal notch, sir, will come down, and then
from the suprasternal notch you will come down.
Downwards, sir. And there is a presence of a ridge and a ridge, sir, in the midline, sir.
So there is a ridge.
Yes.
So that ridge is corresponding to what structure?
Second rib, sir.
No, it will correspond to second costal cartilage.
Costal cartilage.
Okay. And then you come laterally up to the mid-clavicular line.
Yes.
And the space below that is the second intercostal space.
Second intercostal space.
Right. So you start percussing from there. Then what you do?
We keep on percussing downwards, sir, until dullness is reached.
Right.
Sir, which is in the fifth intercostal space, so normally.
Usually the fifth intercostal
space. That is the liver. That is where the liver dullness starts, sir.
Right.
And we continue percussing downwards, sir. Yes, sir. In the mid-clavicular line.
No, if you do not put a mark there, okay.
Yes, sir.
When you are measuring the lever span, there has to be at least one mark, either on the upper side or on the lower side. Yes. Because you will not remember where is that. Like it is the fifth intercostal space, you have to put the mark there, okay? And
yes,
then you start percussing down and see
yes,
that up to what area it is dull. And
yes,
that is the lower border.
Lower border, sir.
Okay. Or the other way is that you can mark this, the upper one, and from the lower side, from the iliac fossa, right iliac fossa, you start percussing up and see that where that dullness comes here.
Yes, sir.
Okay. So this is the way to measure the lever span. What is the lever span which is there in the epigastrium, in the mid-clavicular line, and in the axillary line? What is the normal lever span at these three areas?
In the epigastrium, it is around 3 centimeters, sir. In the mid-clavicular line, it is 12 centimeters, and in the anterior axillary line, it is around 18 centimeters, sir.
So in the mid-epigastrium, it is around 6 to 8 centimeters.
6 to 8 centimeters.
Yes, and mid-clavicular line is about 10 to 12 centimeters. And in the axillary line, it comes to about 14 to 16 centimeters.
Yes, sir.
Okay.
Richard.
Yes, sir.
Can you just show me your A, B, C, D, E, F, G, H, I, all that thing? Just show me that palpation. Yeah. See, these things are to be as only for your checklist. You should know how to make nice sentences and present this case. Okay, these are palpation findings, no?
Yes, sir.
What you should have told, just go back one slide. Yeah. Again, those temperature, tenderness, all that. See, you have written that tenderness present over the swelling on superficial palpation. Anybody will think it would have a ruptured carcinoma cecum with the abdominal wall abscess. That should not come there, number one. What you should have told is on palpation, abdomen is soft, no guarding, no rigidity. Yes, a mass is palpable in the right iliac fossa. You should have mentioned here a little bit of extent. If I see your diagram which you have marked, it is slightly going up into the lumbar region as per this diagram. I am only talking from your point of view. Now just go back. Go back. Yeah, next slide. When the size is 4 centimeter vertical and horizontal 7 centimeter, with such irregular borders, irregular everything, how can it become a globular? What is globe means? What is globe? What is globe?
It is
Globe.
Globe is circular.
So please do not, even though, see, you should remember your diagnosis is carcinoma, surface is irregular, margins are irregular, it can never become a globular. It will become an irregular swelling. So horizontally more, vertically 4 centimeters, surface is irregular, borders are irregular. I agree, getting all around, better to use the word lower border or lower body is very clearly felt. Especially in a women, it becomes very, very important. Consistency is all right. Please remember, do not mention this no movement with respiration. I think I will not, I will definitely not accept this, because when you have got all the borders around, especially upper border so clearly mentioned, never mention this. And again, so no movement with the respiration not required. Lump is fixed. That is all right. When you are told it's fixed swelling, yes, intra-abdominal confirmed by leg raising. Maximum you can turn to one side to know a little bit of mobility, if at all. Pulsation is a good point. Why pulsation important here?
Sir, if the lump is above a artery, or if it is an
lump is artery.
So don't. If the lump is present over a vascular.
Richard, first you listen to sir, then you start answering. Don't jump to answer. First listen to him.
Correct. What you told is right. Fixed lump. So it may be right sitting on the common iliac artery. That is fine. Again, right iliac fossa mass like this. I will not accept to mention. There is no place for you to put a bimanual palpation and ballotability here. Where do you put your hand here?
Yes, true, sir.
If you want to ballot a swelling, it has to be proper in a lumbar region, classical, so that you know to go behind, go in front, and ballot. So these few things are very important here. You should not do that mistakes. Is it okay?
Yes, sir. Yes,
right.
sir.
So make sentences. This is a checklist for you, but when you write the case sheet, it should be in a full sentences. Right. Rajesh sir wants to tell something.
Right. I agree with Rajgopal sir. Any lump below the umbilicus, you should not talk about movement with respiration. You should not. Yes. They usually don't, right?
Yes, sir.
Right. You said that this lump is intraperitoneal.
Yes, sir.
Right. So,
yes, sir.
What is Klein's test? Have you heard of this word, Klein's test or Alder's test?
Yes, sir.
What is this?
If there is a tender mass in the right iliac fossa, sir, when a patient is asked to...
No, first you tell me, what is this test done for? Then you tell me how the test is done.
To differentiate between acute appendicitis and mesenteric lymphadenitis or an ovarian...
Right. So what is the basis of this test? What is the basis of this?
Sir, since the base of the appendix is fixed in the McBurney's point, sir, it will not move, but a mesenteric lymph node or an ovarian growth will, when the patient moves to the left side, sir, it will fall with the gravity, sir. So the tenderness will shift,
right.
Sir.
So these are retroperitoneal structures, yes, right? Sir. While mesenteric lymphadenitis or ovarian are intraperitoneal, right? Yes, so when you turn around, the tenderness will remain present in acute appendicitis or appendicitis, but it will not be there in right.
Yes, sir.
Okay, so you said ECOG. ECOG.
Yes.
What is full form of ECOG? ECOG. Do you know the full form of ECOG? You said ECOG performance status 1. What is ECOG? Have you heard of it? No.
Yes, sir.
What is full form of ECOG? What is the full form of ECOG? Don't tell you, I'll let you know. It is Eastern
Sir,
Cooperative Oncological Group,
Yes, sir.
right?
Yes,
Okay, you've done a proctoscopy also in this patient.
yes, sir. It was done, sir.
Why did you do a proctoscopy in this patient?
Uh,
Why was a proctoscopy indicated in this patient? When your DRE
Sir,
is normal, when your
yes,
DRE
sir.
is normal,
Yes,
you think
sir.
you'll gain anything by proctoscopy?
Sir, to look for any polyp or any.
No, in DRE
That was
you'll feel a polyp. You'll feel a polyp because proctoscopy is not required. Look, you don't put the patient into discomfort just because you want to fulfill all your. You could have done a colonoscopy for all that matters. Why not a proctosigmoidoscopy, right? So
Yes,
if
sir.
there are no indications for it, don't do those tests.
Okay, sir.
Don't even mention it.
Yes, sir.
It's not required. Okay. So what's your diagnosis then?
Ajay sir, you want to ask any question? Ajay sir?
Yeah, Dr. Srinivasan, you're all actively examining the hair split clinical points, so that is why I was keeping mum.
No, sir, you are invited, sir.
Yeah,
You're
yeah.
invited. And he's a second year, sir. So just we thought,
Yeah.
sir is explaining all this thing. Richard, don't get worried, Richard. You're doing
No, sir.
well. Yeah, you're doing very well. See, these are the things, as Abhijay Khanna said, the liver span and ballotability, Rajiv sir said some points. These are the points you have to go and revise again. Next time when you present, you correct all this.
Yes, sir.
You don't
Yes, sir.
include this. So don't be perturbed. Ajay sir, you please carry on, sir.
Yeah.
Any questions you want to ask, or we, as Rajiv sir said, we'll go for the.
Been asked, sir. The point is very clear. It's a fixed swelling, so there is no question of mobility with respiration, and especially lower abdominal swellings, we don't expect any mobility. Swellings attached to moving structures like mesentery and structures near the diaphragm are expected to move. So that logic has to be applied in lower abdominal swelling. Second, the bilaterability and bilateral bimanual palpation is reserved for lumbar swellings only. And that too, in a very big swelling, the bilaterability disappears. And all the points are well narrated. We'll go to the diagnosis. What is your diagnosis, Richard?
Sir, from the history and the examination, I provisionally diagnosed the patient to be a case of carcinoma secum, sir.
Okay. So what are the points against carcinoma secum here?
Against, sir.
It's almost correct.
Yes, sir.
Any
Since
points
the
against carcinoma secum?
He's an older age patient, sir.
Okay.
From the age, he is present. He has loss of appetite.
Okay.
Unintentional weight loss, sir.
Okay.
And then from the examination, sir, his general build is from the nutrition and anemia present, sir.
Okay.
His BMI is less, sir, 18.2, sir. And then on examination, local examination, the lump is fixed, hard, irregular.
Okay.
Okay,
how do you fit your history of some swelling occurring a few months back, which disappeared completely, misleading the clinician as an acute appendicitis and advising elective appendicectomy? How do you fit this history into your diagnosis? It is possible.
Sir, a growth in a cecum can present with acute appendicitis, sir, when the lumen of the appendix is obstructed by the growth, sir.
Okay.
So that can be misleading, sir.
Okay. There is one point. Anything else? A mass coming there.
Yes, sir.
And after
the mass has rapidly increased in size within a small span of time, sir.
Richard, first you listen completely, then you talk.
Yeah, my question is, this man has no mass, nothing. On fine morning, he develops pain and mass. A few days later, the mass disappears.
Yes, sir.
Would it be something else other than acute appendicitis in the right iliac fossa? In fact, that point has come in the discussion earlier. You just think about it.
Richard, you just
Sir,
go back.
Richard is, sir has given a clue. It comes one fine morning, pain and swelling. Been discussed with another differential diagnosis. Rajagopal sir was discussing, no? Richard?
Yes,
You
ma'am.
can say you do not know.
Richard, I'll give you a.
Sir has discussed. Rajagopal sir was discussing.
Ajay sir, you can give the answer, sir. He's the
Richard,
second.
I will give you one more clue. The ways
Yes,
of
sir.
presenting colonic malignancies. One is a mass.
Yes,
Second
sir.
is blood loss, chronic blood loss only.
Yes,
Then
sir.
other left-sided chronic symptoms. Apart from that,
Sir, ileocecal tuberculosis, sir.
no, I am asking the diagnosis is carcinoma cecum itself.
Yes,
But
sir.
at that time, around 4 months back, that
Yes, sir.
focus of carcinoma
Yes, sir.
presented as a particular surgical condition, acute surgical condition, which got relieved.
Yes, sir.
Just think about it. Have you heard of colic intussusception?
Yes, sir.
Yeah. In an elderly person, if you get an intussusception, always think about malignancy, isn't it? If it is
Yes,
an
sir.
infant, you always think about ileocolic, idiopathic, or hypertrophic Peyer's patches, isn't it? Okay.
Yes, sir.
So could it be a colic intussusception? That mass. Ultrasound will completely help you. It will say.
Sir, he will present, if it was an intussusception, sir, there will be present a red currant jelly stool, sir.
No, those things are there in infants. Red currant jelly stool and all. This is a malignancy, a small growth, a mucosal growth, which acted as a focus or nidus, and
Yes, sir.
telescoping happened. After some time, it got relieved.
Yes,
Then
sir.
the lump kept on growing to present size. So
Yes, sir.
this can be a colic intussusception, or could be a appendicular mass on the top of a pre-existing carcinoma cecum.
Yes,
That is how we coordinate and match with the present diagnosis. I think that can totally take you away. In tension during exam, you may present it as an acute appendicitis with an appendicular mass not resolving. So things are in danger, isn't it?
Yes, sir.
In an old man, always your first diagnosis is carcinoma cecum, and you have to fit all those salient events in the past to the present diagnosis, isn't it?
Yes, sir.
Taking everything together, it could be a colic intussusception, which presented as a mass, it disappeared, and the mass kept on growing to the present size. Now it is a fixed mass, and there is pain on the back, everything. Okay, right, carry on.
What will happen in a case of intussusception to the right iliac fossa? What
sir,
is that? What is that sign which is there?
Sign of dance, sir.
Yeah, sign de dance, no?
Yes, sir.
And in the sign de dance, there is a emptiness in the right iliac fossa.
Right iliac fossa. Yes,
yeah, and you get a sausage-shaped lump which is around the umbilicus.
Umbilicus. Concavity is towards the umbilicus, sir. Yes.
Right. Yeah, that's the idea. Okay.
Okay. How will you evaluate the patient? You have a very good clinical diagnosis. Most of the points are in favor of clinical points are in favor of your diagnosis. So how will you proceed?
So we'll do a routine blood. Yes.
Go to diagnose.
Okay. Tell me
A routine.
three important. Sir was asking earlier. Three important investigations you will do.
Sir,
three important investigations in this patient.
Stool for occult blood, sir.
Okay.
Firstly, then colonoscopy. And a CCT of the whole abdomen with pelvis, sir.
Okay. Okay. Okay.
Go to your slide, investigation slide.
What is the role of carcinoembryonic antigen in this patient?
Sir, embryonic antigen can be taken as a baseline for the further follow-up of the patient.
In this patient, I am asking, in this patient, not general. Should it be elevated always in this patient? And if you get a normal CEA level,
yes, sir.
does it rule out carcinoma cecum?
CEA is not used as a diagnostic tool for a diagnostic criteria for a carcinoma cecum, sir, but
Okay.
it can be normally raised in normal individuals
It is
case of
more important in left-sided colonic masses, isn't it?
yes, sir.
Rather than right, number one. Number two, it is not a diagnostic investigation.
Yes,
it is an investigation to help you following up the patient post-operative, yes, isn't it?
Post-operative follow-up, sir.
Okay.
Richard, in colonoscopy, what are the things you are interested to see?
Sir, any synchronous growth, sir, or polyps.
What else?
If the lump is in the intraluminal or maybe extraluminal. If it is in, we can take biopsies as well, sir, to the colonoscopy, sir.
Yes. Anything else? You are suspecting a patient having a carcinoma of the cecum.
Yes, sir.
So you want to see for the synchronous malignancy, you want to see for the primary tumor which is there. What else you want to see on the colonoscopy? You want to see for the pre-malignant conditions which are there, okay?
Yes, sir.
So
anything which is going to change your management.
Sir, presence of polyps, sir.
So what are the various pre-malignant conditions for the carcinoma of the cecum?
Sir, familial adenomatous polyposis, sir.
Right.
Any adenomas, sir.
Right.
And then
which type of the polyps are pre-malignant? Polyps and the adenomas, which are pre-malignant?
Sir, villous are pre-malignant. Villous adenomas are pre-malignant, and the sessile polyps, which are of size more than 5 millimeters, 2 centimeters, are pre-malignant, sir.
So you have to see for the various polyps and the adenomas. You have to see for the hereditary polyposis. You have to see for the some non-hereditary polyposis. So all these things are the pre. So in a case of when you're doing the colonoscopy, because your management will change according to that. So the patient might be having a carcinoma of the cecum, but he has got the familial polyposis. Then the management will change for that patient.
Yes, sir.
Shantani, madam, you would like to ask some questions, madam?
Why do you want to do an chest X-ray? You return? Why? What is the indication?
Ma'am, to look for any metastasis to the lungs.
What type of metastasis? You just elaborate your investigation. Why you are doing a routine blood investigation? Just elaborate your investigation.
A routine blood investigation.
You want to do all this in routine? What are the investigations you want to do?
In routine blood investigations, I would look for hemoglobin level since the patient was paler.
Okay.
And for the LFT, I will look for.
Still, you are not confirmed your diagnosis, isn't it?
Yes, ma'am.
You are in a stage of provisional diagnosis. You are not diagnosed yet.
Yes, ma'am.
So what are the investigations to find your you have to confirm your diagnosis first, then you do all the workups. So what are the investigations you will do first?
Ma'am, and complete blood count, ma'am.
Okay.
Yes, ma'am. Here we may find, ma'am, the decreased hemoglobin level.
Okay.
We may look for, ma'am, LFT, ma'am.
Okay.
We may have raised bilirubin and alkaline phosphatase level, ma'am.
Okay.
We may go for a renal function test, ma'am.
No, still you are not confirmed your diagnosis. What was that mass? Your provisional diagnosis, CSC come.
CSC come, ma'am.
So what is the first test apart from doing a routine investigations? What is the first test? Investigations, we will confirm your diagnosis. This is only the disease is involving the cecum. We have discussed so many other differential diagnoses, isn't it?
Yes, ma'am.
But what is the first test? You want to do it straight away, go and do a contrast CT?
Ultrasound of the whole abdomen, ma'am.
Okay, ultrasound, what are the things you will observe in ultrasound?
Whether the mass originates in the cecum, ma'am. If there are signs of any metastasis to the liver or the momentum or peritoneum.
No, first you discuss about the mass. Discuss about the mass. Then you confirm it is only a. You said there's so many findings, no, irregular, hard inconsistency. See, what are the things you will see in ultrasound?
If the mass,
you didn't mention anything in the ascitic fluid, whether the cecum and the appendix is involved. So you have to elaborate your ultrasound findings. Then only you can go for your contrast CT. Okay.
Yes, ma'am.
Then you can see the liver enlargement. Is there any lesions in the liver?
Lesions in the liver, ma'am.
Okay.
You can look for any ascites or any
fluid in the abdomen.
Fluid or peritoneal.
We have enumerated so many differential diagnoses. No, what are the differential diagnoses you have enumerated?
Ileocecal
tuberculosis. Once you said is ileocecal tuberculosis.
Yes,
you have written so as cold abscess, lymph node. So with this, you can differentiate in an ultrasound, isn't it?
Yes, ma'am.
Then you can go for a CT and a contrast. Yes, so first you confirm your diagnosis, and with your diagnosis, you do the investigation. You select your investigation according to your diagnosis. Okay?
Yes, ma'am.
Ajay Kumar, sir, are you with us, sir? You want to ask management, sir?
No, sir, I don't think. Ajay Kumar, sir, you can, please, sir.
I think, sir.
Yeah.
Yes, sir, please carry on, sir. Management part of it.
Okay. Okay, you have investigated the patient. All the diagnostic tests are positive. Your colonoscopic biopsy result came as adenocarcinoma, moderately differentiated, and your CT has come, and there is fat plane between the posterior abdominal wall and the mass is not clear. The CT suspects infiltration or loss of plane. So that's the final picture. Your diagnosis is carcinoma, cecum. So how will you proceed? All the diagnostic investigations are over. Now you are into the management.
Yes, sir. We'll go for an written and informed consent, followed by preparation of the patient, which is IV antibiotics and bowel preparation. IV antibiotics to be given just before induction. Bowel preparation to be done with, and then we'll go for an exploratory laparotomy and then proceed.
Okay, what is your plan before you should plan for surgery, isn't it? All the investigation results at your fingertips.
Yes,
and what is your plan before putting a knife?
A right hemicolectomy, sir.
Okay. What about the posterior fixity?
Sir,
You can
if
answer,
the
sir.
Yeah, you are correct. You proceed. Richard, you are in the
yes, sir.
right direction.
Yeah. If the structures are invading the if the growth is invading the structures, sir, posteriorly, we can go for an iliotransverse anastomosis of
That
the
depends
growth, sir.
on the type of structures infiltrated. For example, it has infiltrated, it has gone out of the serosa and infiltrated some muscles and unimportant nerve. You will still go ahead with surgery.
Go ahead, sir. Yes, sir.
Because the best palliation is reduction in the tumor size, isn't it?
Yes, sir.
Oh, okay. But if there is very significant infiltration with vascular and all, you will change your decision. Okay. Can you just tell me the systematic approach when you put your knife, you have opened the peritoneum, then you have done a midline incision, the midline extending lower, according to the need you extend, isn't it? The classical midline incision you have done. You tell me step by step, what will you look for? Just for the beginners to understand.
Sir, first we will look if there is any metastasis to the peritoneum.
When you put your knife and open the peritoneum, first you will look for ascites, isn't it?
Ascites.
Yeah. Then you see the omental deposit. You see the panoramic view of the undisturbed abdomen. Then go to the liver, go to the pelvis. The ascites may be there. Look for Bloomer's shelf, isn't it? Don't try to manipulate the swelling at the beginning, isn't it? So you have a good inspection, palpation, the cardinal points like liver metastasis, then peritoneal mets, everything. Finally, you go to the tumor and see gentle palpation, move, see for ascertain that it is operable. What is the difference between operability and resectability?
Resection.
Yeah, a tumor can be operable, a tumor can be resectable, and tumor can be inoperable. These are the three outcomes you expect in any tumor. It's self-explanatory. Resectable means resectable with an oncological clearance. You can extirpate the tumor with oncological clearance. Operable means you may be able to operate upon a tumor. You can remove it, but you may compromise on the margins, the oncological clearance, but in tumor cytoreduction, it is good, isn't it? That is operability. Yes, you'll be able to remove the tumor somehow and get out of it. That is operability, right?
Yes.
Okay. So next, you found to be operable. Okay, I'm giving a clue. What will you do? We are taking a lot of time. One more case.
Right. We'll go for a right hemicolectomy, sir.
Okay. Can you just tell me one metabolic complication of right hemicolectomy? Not pertaining to this patient. Any right hemicolectomy? Not oncological.
You can answer him, sir, please.
Yeah. See, what is the importance of the distal ileum? You all know. Your intrinsic factor is produced in the stomach, and absorption of vitamin B12 takes place in the ileum, isn't it?
Yes.
If you take more than sufficient ileum due to oncological reasons, you may develop a B12 deficiency. Very simple. Okay.
Yes.
Right. Any other problems? Mechanical problems, bowels, after right hemicolectomy, apart from leakage and other things? Patient will have fairly normal bowel function, isn't it? Sometimes he may pass 1 or 2 formed stools more. Okay, it's an oncologically comfortable operation compared to other surgeries. Okay, right? Except the B12. Sir, shall we close it or shall we go to adjuvant treatment and all? Because it's already 9:15.
Sir, we have another 5 minutes to close this patient because I think we have to give time, as you rightly said. I was just waiting because all the seniors are trying to correct this boy, and he has prepared very well. Probably he is being in the secondary, he finds difficult. Otherwise, Richard is trying out and he's bringing out his best. Thank you, sir. Thank you.
Okay.
Maybe, sir, you can give your closing comments, like where all the lacuna were, how the boy can improve himself, like that. You
just
can
a fairly nice presentation. Only thing, as one of the senior surgeons suggested, you should tell as a story. Madam was also telling, because we will not forget then. Otherwise, your ABCD will not comprehend during the exam time. So always take all the points and tell it as a story. That is one. Second thing, always try to fit things. Do not try to make controversies. Even if there is a point which is not fitting, try to fit it by just like our colophonic intussusception. These are the small tips we all do. When we were postgraduates, we also did the same thing. Just fairly a good presentation. Richard, thanks. We did not get time to discuss about adjuvant treatment. I think we'll come to the next case.
Richard? Richard?
Yes, ma'am. Yes, ma'am.
Yeah, it's a good presentation, but you can reduce some of the history, like immunization history and the detailed family history and about the religion. Anything specific you have to say the religion? I think the small things you can avoid it, and you can enumerate history. That is, the examiners should virtually analyze imagine the picture of the patient. That's why you must present. Okay, so everything you're just filling the blanks like thing. You have to anyway make a sentence, make a whole story like that, and present it. That will be very good. And with your diagnosis, always first confirm your diagnosis. This is this. Then you can do all the simultaneous investigations or workup like investigations. Okay, nice presentation, Richard.
Thank you,
Thanks, everyone.
Thank you,
from my department and institute, I thank you all. I'm Dr. Ganguly. And Richard, please thank them profusely. They have corrected you.
Thank you, respected teachers, for correcting me. It was a good opportunity for me to learn a lot.
Chennai, sir.
And I'll definitely correct myself.
Any question? Anything, sir? Rajay Khanna, sir.
Sir, please stay with us. Rajgopal, sir, you wanted to tell something before we move on to the... You're okay?
No, I just want to say hello to Ganguly, sir. That's all.
Yeah, hello, sir. Thanks very much for correcting my child.
No, sir.
Thank you very, very much. I'm really grateful
sir,
to you.
Yes, done well, sir.
These thanks is from my institute, from my department. Thanks very much. Thank you.
Thank you, sir. Yes, sir.
Especially you.
Thank you, sir. Thank you, sir. Thank you so much. Kanna, sir, your closing comment, sir. We move on to the next case.
You know, whenever you get a case of the right iliac fossa lump, which is there,
yes, sir,
then usually there are 3 differential diagnoses which you have to settle that.
Yes, sir.
Is it a case of carcinoma of the cecum or ileocecal area, or is it a ileocecal tuberculosis, or it is appendicular? There are many other differential diagnoses which are there, whether it is parietal or intra-abdominal or retroperitoneal lumps are there. But these are 3 most important differential diagnoses, and you settle your diagnosis based on that.
Yes, sir.
And once you get, and in that with the diagnostic investigation which will be there is the colonoscopy which you will be doing here. Colonoscopy will give you a tissue diagnosis which no other will give that. So for differentiating between ileocecal tuberculosis and the malignancy, you will do the colonoscopy, and based on that, once you have made the diagnosis, you decide upon that. Like Dr. Ajay Kumar give you the scenario about that this patient lump was fixed to the posterior abdominal muscles there, then probably you will not jump if the patient is not in a obstruction or the patient is not bleeding. You will go for the neoadjuvant chemotherapy in this patient. Prepare your patient for that and make it a curable patient. You know, if you give the patient neoadjuvant chemotherapy, then if you leave the residual disease there, then this patient is not curable. But here you can make it almost a curable cancer, carcinoma of the cecum which is there, and with the help of now the total mesocolic excision which is there, which has come in a big way for the colonic malignancies, you can almost cure these patients for a very long time. Okay, thank you.
Yes, sir.
Thank you, sir. Thank you, Richard. Thank you, Ganguly sir. We request you to stay back. Richard, you would like to have any doubts clarified by the examiners? You have any questions to be clarified?
Sir, nothing
Feel
is
free
coming
to
right
ask.
now to me.
No problem, Richard. Our faculty are always there to help you out. If you have any questions, you can write in the chat box. They'll be able to answer. Thank you, Richard.
Yes, sir.
Thank you,
Thank you, sir.
Ganguly
Thank you,
sir,
sir.
for giving your PG. And we request Vignesh to start his presentation. Vignesh, are you trying to share or you request Srinivasan sir to share, ma?
I am trying to share, sir.
Okay, I think we're able to see.
I am sharing.
I'm not sure. Srinivasan sir shared or you shared?
I shared, sir.
Srinivasan sir, I will unshare so that let him advance the slide, sir. Can I do it, sir? Yes, sir. Vignesh, you try sharing now, ma.
Yes, sir.
Are you able to do?
Yes, sir. I am moving the slide, sir. Is a slide share?
Vignesh, slide share is on. I think I will request Srinivasan sir to share. There is some challenge from your side. Srinivasan sir, sorry, sir. Can you please share this, sir?
Yes, sir.
Yes, sir. Yes, sir. Please start your presentation, Vignesh.
Good evening to everyone present here. I am Dr. Vignesh, a third year postgraduate from Tirunelveli Medical College, Tirunelveli. Today I am going to present a case of about ulcer located in the scalp. 70-year-old male patient named Mr. X, coming from Alangulam, who's a farmer by occupation, has come to OPD the complaints of ulcer proliferative swelling over the scalp for the past 1 year and a swelling below the left ear for the past 4 months. History of presenting illness: the patient noticed a swelling over the scalp before 1 year, which was insidious in onset and was slowly progressive in nature. But by the past 6 months, the swelling rapidly increased in size with ulceration to reach a present size. The patient has history of pain over the ulcer, which is a burning type of pain, intermittent in nature, and it has no associated aggregating or relieving factors. History of blood discharge from the ulcer for the past 4 months. History of swelling below the left ear for the past 4 months, which is insidious in onset and was progressive in nature to attain the present size. And the swelling was not associated with pain. No history of trauma, no history of fever, no history of loss of weight, loss of appetite, no history of otalgia, no history of symptoms like cough, breathlessness, bone pain, or jaundice. Past history: patient is not known case of diabetes, hypertension, bronchial asthma, pulmonary tuberculosis, no history of similar illness in the family, no history of previous surgery, no history of previous irradiation. Personal history: the patient takes normal non-vegetarian diet. He has normal sleep and appetite. He is not a known smoker or alcoholic. Treatment history: the patient had regular dressings for the past 6 months at a local nearby primary health care center. This is the case picture, sir.
Wait, but let the faculty ask the questions.
Okay.
Sir, Khanna, sir, please.
What is the duration of this ulcer?
6 months, sir.
It's only for 6 months. And
Yes,
before that there was nothing there.
No, sir. Before 1 year, the patient had a swelling, but only for the past 6 months, he had a ulcerated swelling became ulcerated, sir.
Did he say what was the color of this swelling when it started?
No, sir, he was unable to notice the swelling, sir. He just only felt.
And which group of the lymph nodes you think enlarged in this patient? You said there is
It's another swelling below the left ear.
So those are lymph nodes probably, isn't it?
Mostly probably suboccipital group of nodes.
So just by looking at this swelling, what do you think what it is? Or looking at
the
this ulcer
swelling,
which is there, yeah.
Yes, so the ulcer is an chronic non-healing ulcer. It's an also proliferative growth, and also looking at the duration and also looking at the location, it could be a malignancy, squamous cell, most probably squamous cell carcinoma.
So can you think it's a benign ulcer in any way? It has to be a malignant ulcer, isn't it?
Yes, sir.
So you have to tell in the malignancy that what type of the malignancy it is.
Squamous cell carcinoma.
Yes,
You know, the duration here is around 6 months.
6 months.
And having such a big ulcer which is there in the squamous cell carcinoma, it may be there. I'm not saying it is not there, but looking at the color of the swelling, which is blackish in color, what do you think? It looks black.
Yes, sir. Maybe verrucous type.
No, what is the other malignancy sir is asking you? What is other skin malignancies?
Melanoma, but basal cell carcinoma.
Yeah, but you know, it cannot be a basal cell carcinoma, can it be?
No, sir. Small nodular types of basal carcinoma.
You have to either go in between the melanoma or a squamous cell carcinoma.
Squamous cell carcinoma.
These are the two things. Or rarely it may be sometimes a sarcoma, it may be there. That is another possibility which I will keep in mind in this video.
Okay, sir.
Okay? So these are two skin malignancies which are there, and then third is the sarcoma also there.
Okay, sir.
Right. Ajay Kumar, sir, you would like to...
So at the end of the history,
sir,
you have not started examining the patient. You have taken a history. Since it is so evident, you saw the swelling, isn't it, Vignesh?
Yes, sir.
Okay.
Yes,
so
sir.
what things which comes into your mind apart from squamous cell carcinoma? You said squamous cell carcinoma. Agree.
Okay, sir.
Anything else?
Okay, sir.
At the end of the history, you get some diagnosis in your mind. Then you confirm by clinical examination. At the end of the history, apart from carcinoma, squamous cell carcinoma, anything else come to your mind?
Sebaceous horn.
Okay, sebaceous horn, but the imagination is so wide. Okay,
yes, sir,
so let me ask you another question. Is there any history of slow bleeding which stains his turban, or he keeps cloth over that? History of bleeding from the lesion?
Yes, sir. History of bloody discharge from ulcer, sir.
Yeah, that could be a reason for blackish color, isn't it?
Okay,
that
sir. Yes,
bright blood can mimic a black colored tumor, as Khanna sir was pointing out, could be a melanoma. But everything put together, you still believe that it is carcinoma, that is squamous cell carcinoma. So, could you explain that dark color due to a dried blood, slow oozing, again it stops, recurrent, that history should have stressed in the history of presenting illness. Recurrent history of oozing from the growth is there, right? Okay. Okay.
Dr. Vignesh?
Yes, sir.
Dr. Vignesh?
Yes, sir.
Yeah, just want to ask you, your patient, it started as a swelling, correct?
Yes, sir.
Now, is there a difference between, 1 minute, is there a difference between lesion started as a swelling and an ulcer? or a ulcer and then followed by a large growth. Any difference is there? I'm only asking you for the sake of knowledge. That's all. Show that your slide, first slide, that history of swelling, something you had written there. Yeah, just look at that here. You have written there, patient noticed a swelling over the scalp, correct?
Yes,
Is it a wrong statement or correct statement? No, I just want to ask.
Sir, sometimes squamous cell carcinoma initially presents as a macropopular.
No. The important point you should try to understand is it could be a lesion arising from the adnexia. What is adnexia?
I can get it, sir.
What are adnexial tumors? Skin appendages.
Yes, sir. Wart. Papilloma.
No. Talk only malignancy, no. See, we are not talking about benign diseases like keratoacanthosis, seborrheic keratosis, etc., etc. Your patient has got a lesion. I just want you to keep it in mind whenever you give a diagnosis of a squamous cell carcinoma arising from the skin. Better use the word initially epithelioma. It is to be on the safer side. Squamous cell carcinoma is a histological diagnosis, even though most of us will use that, no problem. But epithelioma is one lesion, number one. Number two, it always starts as an ulcer there. You understand, no? It starts as an ulcer. It cannot start as a nodule. If it is a nodule, it has to be something other than. It can be a sebaceous carcinoma, adnexial tumors, seborrheic keratosis. So many other things are there. Because is a 70-year-old farmer. Today you are seeing a case like this because it is 1 year duration. It's definitely a slow-growing tumor, no doubt about that. It can very well fit in the squamous cell carcinoma. But if this is a 50-year lady with a small swelling in the scalp and which is growing rapidly, what will you think of? Somebody tries to incise it.
Melanoma.
No. Swelling I said. So follicular carcinoma thyroids can present very.
It's a pulsatile secondary.
So like that. So one should be careful. So I just want to bring your attention. When the lesion is started as a swelling, then also we should consider adnexal tumors also. Yeah.
Okay, sir.
That's all.
I'd just like to tell you that adnexal tumor consists of sebaceous glands, hair follicles, and sweat glands, and the nerves. So you must think of these. These are very common there on the scalp. Trichomonas, sebaceous, all that kind of thing. Also, melanoma can present, but it's rare to be present in the upper part. But they can also present. Most commonly is squamous cell carcinoma because of actinic, because of exposure to the sun on the scalp. So they have actinic changes, and that can present as squamous cell carcinomas. Okay. Even basal cell carcinoma is uncommon. Is not uncommon. Even basal cell carcinoma can be there.
Dr. Shantini, madam. Dr. Ajay, sir.
Okay, madam. Okay, right. Vignesh, we'll go to the examination. As sir was rightly said, telling there is a small problem because it is a big tumor. Slow going, swelling, ulcerating later is a possibility.
Yes, sir.
Okay, we'll keep in that mind when we examine the patient. We'll go to the examination.
General examination. The patient was conscious, cooperative, oriented, afebrile, moderately built and nourished. Hydration was fair. No pallor, no icterus, no clubbing, no generous lymphadenopathy, no periedema. Eastern Cooperative Oncology Group score was 0. Vitals, pulse was 84 beats per minute, regular in rate, rhythm and volume. BP 120 by 80.
Anything positive?
Sir?
Any positive findings in general examination?
No, sir.
Nothing. Okay, go to the local examination.
Local examination on scalp. After obtaining informed verbal consent, examination of the patient was done in sitting position with full exposure of the head and neck. inspection, a single also proliferative lesion of size 10 into 8 centimeter was seen over the left parieto-occipital region of the scalp, extending 6 centimeter from above from the occipital protuberance and 4 centimeter above and medial to the left earlobe. It was irregular in shape and had irregular margins.
Okay.
It had raised and everted edges. The floor was filled with fluff and necrotic tissue. The skin surrounding the ulcer is normal. And another satellite nodule of size 0.5 into 1 centimeter is seen 4 centimeter below the main ulcer. Another swelling suggestive of a lymph node of size 4 cross 6 centimeter was seen 3 centimeter behind the angle of mandible, 4 centimeter below and lateral to the occipital protuberance in the posterior triangle of left side of the neck. It was oval in shape. The skin over the swelling is normal. The surface was smooth. It has a well-defined edge, and the skin over the swelling is normal. On palpation, in the inspectory findings were confirmed. A single ulcer polyp size 10 cross 8 centimeter was seen over the left parieto-occipital region of the scalp, extending 6 centimeter from the occipital protuberance and 4 centimeter above medial to the left earlobe. Base was indurated. It didn't bleed on touch. Ulcer was mobile in all directions. And no warmth or tenderness in the skin surrounding the ulcer. A satellite nodule of size 0.5 1 centimeter was seen 4 centimeter from the main ulcer. The nodule was firm and was mobile.
Okay,
Another
interrupt. You said the ulcer is not mobile.
Yes, sir. Ulcer is mobile, sir.
The whole swelling is mobile, isn't it?
Yes, sir.
Okay.
Another swelling of size 4 cross 3 centimeter seen 3 centimeter behind the angle of mandible, 4 centimeter below and lateral to the occipital protuberance. It had no warmth, no tenderness. It was oval in shape, surface smooth. It has well-defined edge. Consistency, it was hard in consistency and was fixed to underlying structures. And the swelling was non-mobile. It was non-fluctuant, and the skin over the swelling is pinchable. Systemic examination. CVS S1 S2 heard, respiratory system, bilateral RNT equal, no response, abdomen was soft, and central nervous system, no focal neurological deficit. The diagnosis squamous cell carcinoma, left parieto-occipital region with the TNM staging T2, N2A, and MX.
How could you say there is a satellite nodule, and how could you say there are lymph nodes? How do you differentiate between these two things?
So satellite nodule, it was seen just 3 centimeter from below from the main ulcer.
Satellite nodule is a classical description for another entity. The word satellite nodule itself points that the diagnosis is something else, isn't it? That is what Khanna sir might have intended by asking this question. The satellite nodule is classically used in another condition. What is that condition? In-transit lesions, satellite nodules.
Malignant melanoma.
Okay. Right, carry on.
Khanna sir's question you answer.
Answer sir's question.
The lymph node is, the edges are smooth, well-defined edges, sir. And
but how do you differentiate between a satellite nodule and a lymph node? You are very categorically saying that there is one nodule which is 4 centimeters from the lesion. That is a satellite nodule, and another you are feeling the swelling as the lymph node in the other area. I say all are the lymph nodes. I say that swelling which you are feeling is also a lymph node, and the other group also the lymph node is there. So how will you differentiate between a satellite nodule and a lymph node?
Lymph node we can examine by examining the consistency of the swelling.
Consistency will be the same, it will be same. Just tell whether you are able to pinch the skin over that or not.
Yes, sir.
If you are able to pinch the skin over that,
okay,
then it is probably the lymph node. If you are not able to pinch the skin, then maybe it is satellite nodule. But you know,
Okay, sir.
the skin can be involved also by the lymph nodes also, Jay.
Okay, sir.
See, Dr. Vignesh,
Yes, sir.
picture what you have shown to us is different from picture at surgery. Okay, that surgery, there is a big picture which we are able to see. You understand, no? That's why this
Yes, sir.
confusion and lot of questions had come. Okay, number one. Number two,
Okay, sir.
that another swelling, what you are referring, what is that swelling?
So small nodule was seen, sir.
No, this
Skip.
4x3 seen 3 centimeter behind the angle of the mandible.
Yes, sir. That is a lymph node, sir.
Why not which lymph node?
Posterior. It was above the sternocleidomastoid.
What about the sternomastoid? That's a suboccipital node. Okay,
Okay, sir. Okay.
you should know suboccipital node. What are the conditions
Okay.
where you get suboccipital node other than this malignancy, whatever scalp area drainage? Any other? Any other? See, this is how we assess the postgraduate exam. So it's one of the
Okay, sir.
features also in a non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma. Okay.
Okay,
Always
sir. Okay,
when
sir.
you write later, you understand.
Okay, sir.
Now you
Okay,
concentrate.
sir. Okay, sir.
So just remember suboccipital node. So what you can straight away
Okay.
we expect you to say a lymph node, suboccipital node is palpable, whatever that.
Okay.
And that hard fixed, don't say not fluctuant. It is not required. Okay. When
Okay,
this
sir.
node is hard and fixed, it is unnecessary. Don't get into trouble.
Okay,
Okay.
sir.
Thank you.
Okay.
Vignesh,
Sir, ma'am?
Yes, madam.
did you palpate the underlying scalp bone, underlying the ulcer, whether there is an depression in the occipital bone? Did you palpate?
Yes, ma'am. My palpate, there's
Because
base was
you said the
indurated.
ulcer is mobile. So what is the underlying bone? Is it depressed or it's normal?
It was normal.
It was a palpatory finding.
Yes, ma'am.
This is all because you said the ulcer is mobile. When the ulcer is mobile, can you palpate the base? If you palpate the base, madam is asking, what is the base you palpated? Is it, madam?
Yes, sir.
Did you feel for the underlying bone? You say
Yes, sir,
yes or no? Yeah, I did
yes,
palpate,
yes,
sir.
Yes,
Was the bone normal?
Yes, sir, it was normal. It was not fixed to the bone, sir.
And one more thing, as a postgraduate, you can say it is the lymph node enlargement. To say other than there is a swelling under the mandible measuring. So as a postgraduate, you can straight away go and say it is a lymph node. There is such and such group of lymph node is palpable. The size, shape, and is it a tender? Is it a fixed or mobile? You can straight away say which group of the lymph node is palpable. Okay.
Okay.
Okay. Let's proceed.
Ajay, sir?
Yeah. So
Okay.
we have some confusions at the end of our clinical examination regarding the origin of the swelling, as seniors were telling. So what is the way out? Proper preoperative diagnosis before embarking on surgery. What do you do, Vignesh?
So first we have to confirm the diagnosis by taking a biopsy, sir.
Okay.
And edge wedge biopsy is ideal, sir.
Okay, wedge biopsy from the normal as well as the ulcer.
From the growing part of the ulcer, sir.
It is very difficult in this case.
Yes, sir.
The entire area is abnormal with an ulcer on the summit. So where will you take the biopsy?
From the where the normal skin and the ulcer meets, that place we can take the ulcer, or we can do scraping of the ulcer and do examination from that scraping, sir.
It is better.
Or punch biopsy can also be done, sir.
Better to take a tissue biopsy, a good wedge of tissue.
Okay.
Because we are suspecting some other conditions also, other than squamous cell carcinoma. Okay. So the wedge biopsy results. You're expecting squamous cell carcinoma, isn't it? Keratin pearls, classical
keratin pearls.
Carcinoma. Okay. How do you account for this large size and long duration?
Sir?
Large size of the lesion and the long duration.
Okay, sir.
How will you account these 2 points in squamous cell carcinoma?
Slow growing
Yeah,
tumor.
can be
So,
slow growing tumor.
yes, sir. And I couldn't get to understand your question, sir.
The question is, we all talked about the possibilities of it being other than squamous cell carcinoma because it is a deep tumor with ulceration, started as a lump, isn't it? Those things are not really fitting with a squamous cell carcinoma. An ulceroproliferative lesion growing sideways is a classical presentation. So we'll keep in mind the rare possibility of other things like non-Hodgkin's lymphoma and even melanoma, not 100%, very, very rare, but still possible. So you need a good chunk of tissue for tissue typing and other things. Okay, right. So the diagnosis comes as squamous cell carcinoma, right? Classical, moderately differentiated, or even not very aggressive. Yeah, not poorly differentiated.
In this case, it was. Okay.
In this case, what was the report?
In this case, it was poorly differentiated squamous cell carcinoma, sir.
Okay. Then how will you explain the history? Your history is around 1 year, and it is slowly growing. For the past 6 months, it became poorly differentiated. Started growing faster. Okay. Right. So the diagnosis is confirmed. It's a squamous cell carcinoma. Then what is the next thing you will do? Since it is a poorly differentiated, you will do a metastatic search also, isn't it?
The workup, yes, sir.
Okay.
You have to look for the associated lymph node involved. So you have to do contrast enhanced CT of the head and neck region, sir. Draining, yes, sir. Draining. Then CCT neck has to be done, sir, to check for the node status.
Right.
Yes, sir. Yes, sir. In this, then routine blood investigations.
Okay.
And yes, sir.
Okay. So you have lymph node positivity as well as a poorly differentiated carcinoma.
Yes, sir.
So how will you?
Then lymph node, the FNAC from the lymph node should also be done, sir.
Okay, done. Positive.
Yes, sir. Yes, sir.
So you need to have a loco-regional control, isn't it?
Yes, sir.
Okay. And overall, what do you think the prognosis is? It is good.
Sir, but prognosis depends on few factors. First, the size of the tumor. If the tumor is more than 2 centimeters.
In this patient.
In this patient, it is poor prognosis only, sir, because the tumor size is more than 6 centimeters. Depth is greater than 6 mm. Also, in the differentiation, it is poorly differentiated. So, more chances of having poor prognosis only, sir.
Okay. What do you do for loco-regional control for this patient?
Control surgery and
what surgery?
Post-op wide local excision of the tumor, sir. Then, as the lymph nodes are involved, we should do radical neck dissection, sir. Then post-op radiotherapy has to be given, sir.
What is the problem with radiotherapy here? Generally, scalp carcinomas, squamous cell carcinoma, we don't give radiotherapy, isn't it? Wide excision is the best treatment, isn't it? But head and neck tumors, we give radiation in plenty, isn't it? Very common. But scalp skin tumors, usually general post-op radiation is not given. Wide local resection will be more than enough with a flap cover if needed. Did you have a flap cover here?
No, sir. Flap cover was not given for this case, sir.
Why? You could approximate primarily. Primary closure was possible?
No, sir. We have left the raw area open, sir. The case was discussed in the tumor board, and it was planned for flap cover after receiving the margins. If the margins are free, then they're planning for flap cover, sir. If the margin is positive, then again 2 centimeter clearance is given, and
Vignesh, there is a basic problem in that planning. See, flap cover is, the ladder of tissue closure. You, at no cost, you are able to approximate. You have a big defect, you have a flap cover. So what is the point of re-excision? You have to have a liberal excision, make a wide tissue defect, make a good flap cover. So don't give room for a second excision, right? You have the radiological images, you have the clinical, you have the intraoperative assessment. So you are not supposed to leave a positive margin, isn't it? You can go wider, make a good excision, and make a flap cover. So I didn't understand the rationale of your tumor board's decision. I would like to get the senior's opinion on this.
Whether the periosteum was involved or not.
The periosteum was not involved, sir.
So the periosteum are living there, and there is such a big defect is there. Would you put away graft there?
No, sir. Graft was not put, sir.
Why you are leaving the area raw there? I say that if the periosteum is not involved, you could have very well put the simple skin graft there.
Yes, sir, but
no, Vignesh, what was your margin clearance?
In this case, we gave 1 centimeter margin clearance, sir.
What did you do to that satellite nodule which you said?
So that was excised individually, sir.
Did you get the final biopsy report of this patient?
Yes, sir. The surgery was done yesterday only, sir. Biopsy will be getting next week.
And what was done for the lymph nodes?
Lymph node radical neck dissection was done, sir.
Means from level 1 to level 5, you have removed everything?
No, sir. We removed level 5, level 2, 3, 4, 5, sir. Postolateral neck dissection was done, sir.
All the posterior triangle lymph nodes and the
upper jugular posterior triangle lymph nodes and the jugular level 2, level 3, level 4 lymph nodes were removed, sir.
Did you do the FNAC of the lymph nodes beforehand?
Yes, sir. It was suggestive of yes, sir, suggestive of metastasis deposit from squamous cell carcinoma.
Okay, is there any, you said you will give a post-op radiation depending on the histopathology report. What about chemotherapy? Any role for chemo?
Squamous cell carcinoma responds poorly to chemotherapy, sir.
Okay.
But cisplatin and 5-fluorouracil can be given as concurrent chemo radiation.
Yeah. So this, since being a special tumor, such a poorly differentiated with lymph node mets, in this particular case, I think there is a role for chemo. And the TPF is the popular regime. You have the cisplatin, 5-FU, and doxycycline. So generally, skin tumors, squamous cell carcinomas doesn't need chemo or radiation. But this is a special case. Old man, poorly differentiated, plenty of lymph nodes. So the metastatic potential, the distant metastatic potential is very high, isn't it? So there is a role. You have to treat it as a head and neck malignancy probably. A poorly differentiated head and neck malignancy where you make a complete wide excision or full thickness excision with a flap cover like PMMF flap. So I think to summarize, this patient needs a flap cover. Patient needs post-op radiation. That too, not the direct radiation, electron beam radiation to protect the bone. Then you have the chemo. I think that should be the correct decision of your tumor board also, isn't it? What is the decision of your tumor board apart from surgery?
Post-op radiotherapy is planned, sir.
Okay.
Yes, sir. Post-op radiotherapy is planned.
You are planning chemo later? No.
No, sir. You have to.
The chemo depends on the grade of the tumor mostly, isn't it? This is a poorly differentiated. There is a very high chance of distant metastasis. And cutaneous nodules is another indicator for a future cutaneous nodules anywhere in the body, isn't it? So everything put together, this is a highly aggressive epithelioma, has a potential of distant metastasis. I think chemo has a role here. I think Professor Khanna will also agree with me.
Dr. Ajay, I am not sure that. Have you ever seen a satellite nodule in a squamous cell carcinoma?
Yeah, that is really a problem, sir. I did not open that discussion because then the entire track will change.
You know, because excising the two,
sir, I have seen
once a satellite nodule is there, then everything has to be excised in one go.
Yes, correct.
You cannot excise one satellite nodule at one place and you excise the other. I'm not sure that how much is the...
Another problem is some microscopic satellite nodules will be there without being palpable.
Yeah.
It will appear later.
That's right.
But the cutaneous metastasis is another possibility, sir. Not the satellite nodules. Suppose in highly aggressive penile tumors and all, we see cutaneous metastasis on the shin and all. So that is a distant metastasis actually. Probably that is also a possibility.
I'm sure it was not a curative surgery. That's why we can.
Correct. We can't call it as a curative surgery, even though we did a wide excision of the nodule, radical neck dissection, taking into account the high-grade tumor, the satellite nodule or the cutaneous nodules. So it may be curative, can be a palliative also. That time will only say. So the oncologist will take a decision to include all the weapons to fight at it. That is my view on that.
Okay.
So shall we close the discussion, Dr. Kanagavel?
Sir, I am one moment.
Okay. Madam, Shantini madam.
Yes, sir. Yes, sir.
Shantini madam, your closing comments, madam.
No, what that regarding the satellite nodule, what was the history from the patient? Vignesh, did you ask anything from the history, anything from the patient?
The patient didn't know about didn't notice, ma'am.
Okay.
It could be a lymph node also, madam, from the...
Yes, sir.
Because suboccipital lymph node can be interpreted as a nodule, probably. Only that will be known after the detailed histopathology report.
No, my doubt, sir, one doubt. Why do you have given such a mobile ulcer? Why do you given a 1 centimeter clearance, as you rightly pointed? No, sir. You have done a wide excision and a closure. What was the planning? And keeping the raw area, sir. Vignesh?
Ma'am?
So what was the tumor board decision? Why do you keep the wound raw as far as?
In this case, there's a risk of margin.
So what you made to think that positive margin? What made you to think?
Because the poor prognostic factors. Size was more than 6 centimeters. Depth is 18 mm. Also, the poorly differentiated poorly differentiated squamous cell carcinoma. So there is a high risk of margins being positive. So it was concluded in the tumor board for the for Y location. After the HB report comes, if the margins are free, the immediate flap cover was planned, ma'am.
Madam's question and my question, why do you want to be stingy on the margin? Anyway, you are going to make a flap. So why don't you make it 2 centimeter or 3 centimeter, reducing the chance of the margin being positive? That is a practical question we're all asking.
Maybe
that is beyond his control, probably.
Maybe
Yes, sir,
faculty
yes,
will be able to answer the question. Maybe definitely not a very conventional case, or but definitely a very different case for a presentation where everybody is thinking differently. That obviously means there are many options to skin the cat. That is what I would say. Kanna sir, you wanted to tell something.
Okay.
No, just
okay.
Still I am not.
Okay.
No, still I am not sure that what is the diagnosis in this patient. Okay, we have to see for the full histology report and then only make the final comments on that. Yeah. And maybe Dr. Kanagavel, you may find it out and tell us what was the final biopsy report of this patient.
I will inform, sir. Yes, sir, I will inform, sir.
Next class you can inform.
You get all the details.
Yes, sir.
And the week after next, by 14 days, you will get the reports.
Right.
Yes, sir, I will message you, sir.
Once again, you discuss, so you personally go to the tumor board or the oncologist and said, these were the suggestions given, sir. Ajay sir said chemotherapy. What is your suggestion, sir? You get knowledge and you come and share it, no problem.
Okay.
It's a tricky case, even we are.
It's a special case, so yes, the discussion is also special.
I think.
Sir also said that we're not about the chemotherapy. So you once again go.
Dr. Kanagavel, if you
especially the satellite nodule, sir.
Yes,
satellite nodule pathology is also interesting.
Get the biopsy report.
Biopsy report, after getting, I will message you, sir. Inform you, sir.
Okay, thank you very much for the nice presentation. We are all eager to know, like Kanasa, what is actual histology report.
You, Dr. Kanagavel, you remember that once there was a presentation of a tumor like that in the arm, in the right near the elbow, there was there, and that was also a very tricky type of thing with it. Yeah, long back. I think about 3 or 4 months back. Yeah.
Yes, sir. No, actually, sir,
I was a similar type of the tricky case. Yeah.
I was asking Jailal sir to give a non-conventional case because we do more of breast, thyroid, and abdomen. So he said, okay, we will give a challenging case, but I never thought this will be a big challenge. Jailal sir is in a
this is also interesting, sir. Sir, this is also interesting, sir. You are learning from the seniors. Definitely, sir. This is also a learning for us also, sir.
Okay.
One thing is very sure, whatever is from Jailal sir is googly.
Googly.
Sir will be joining for the next week. And I also should thank officially Shantini madam and Ajay Kumar sir for joining us today. And our own faculty, Kanna sir, Hitesh sir, Srinivasan sir, Vivek sir. And I think today we had the pleasure of having many faculty. Dr. Som Prakash Basu sir was there, Guru Shantappa sir was there, Dr. Ganguly is there, sir, all through. Dr. Madhu Murali was quiet because he wants to listen, he said. So many faculty was there. I think 8 o'clock maybe suits many faculty. In fact, I was sending a private message to Kanna sir, should we make it 9 o'clock? Then Kanna sir said, we will, as promised, let this month go. He said, if you are having, like I have proposed one case after at 9 o'clock. It looks like 2 cases are needed because it gives a variety and it gives the examiners also a chance to discuss many different things. So till this year end, we will have 2 cases. Then maybe by January, we will review the situation, sir, and then we will think about having one change of time. Till then, we will have 8 to 10. And I also should thank both the PGs. In fact, now the students are learning to come onto the forum, and I thank all the faculty for patiently correcting the postgraduate deficiencies. I won't tell deficiencies, they are put back on track, and many common things are discussed again for the benefit of the students. And I also wish all the students to take note of it. This is available as a recording forever. So you please go through the recording again, get back to your books today or even by this weekend, you cover up all the lacunar areas so that you catch up in full. So with that few words, any faculty would like to tell any comments before we close?
So it was a wonderful opportunity, Dr. Kanagavel, to interact with seniors.
Thank you, sir.
And thank you so much. And I'm participating for the first time here. It was very interesting. Thank you so much. Thank you very much.
Thank you, Ajay sir. Maybe I can request your PGs also to present here.
Yes.
This is happening from the time COVID began, sir. We have now close to 70 classes happened so far.
Okay.
So all these things are available in the YouTube channel also. I request you or any of the PGs who are interested are more welcome to come in, sir. And anytime you have time also, you please join us, sir. We'll be happy, more than happy to have your expert presence, sir. Anthony, madam, your word.
Sir, thank you so much, sir. Thank you. You have given me the opportunity to join with the senior and Jambawan colleagues, sir. It's very nice, pleasant evening, sir. Thank you, sir. Thank you,
Thank
sir.
you, madam. Thank you.
Yes, sir.
Thank you.
Okay, good night.
Good night, Kanna, sir. Can we close, sir?
Good night, Kanna, sir. Good night.
Ritesh, sir, anything? Rajesh, sir, thank you.
Thank you, sir.
Vivek, sir, thank you.
sir.
Thank you, sir.
Thank you,
Thank you,
Vignesh,
sir.
and thank you, Dr. Rajesh
Thank you,
Parla, for joining us. Thank you, friends who are joining the YouTube. We look